Two patients walk into your clinic. One says, "Doc, I think I can breathe in, but I'm finding it difficult to breathe out." While the other says, "I feel like I cannot take in a full breath." Same symptom, breathlessness, but entirely different diseases. I'm Nabeel, this is Pathologist, and today we'll simplify obstructive versus restrictive lung disease. Let's start with the single most important idea. Obstructive means problem with air going out. Restrictive means problem with air going in. In obstructive lung disease, there is air trapping within the lung. While in restrictive lung disease, there is reduced expansion of the lung. In obstructive lung disease, there is something blocking the flow of air out. It may be due to airway narrowing or mucus or loss of elastic recoil. Think of it like a crowded hall from where people are trying to get out. The door is open, but it's too small. Coming to restrictive lung disease, here there is no obstruction. Air can go in, but the lung cannot expand properly. Imagine a hall where a lot of people want to come in and a lot of people are standing outside. The door is big enough, but the hall is too small. That is restrictive lung disease. Spirometry can differentiate both conditions. Imagine what will happen to forced expiratory volume in the first second, FEV1, and forced vital capacity. In obstructive lung disease, since there is an obstruction, the patient can only slowly push out the air. So, forced expiratory volume in the first second, or FEV1, significantly reduces, while forced vital capacity is more or less normal or maybe mildly reduced, as lung volume is more or less normal. So, FEV1 by FVC reduces and is usually less than 0.7 in obstructive lung disease. Coming to restrictive lung disease, what do you think will happen to FEV1 and forced vital capacity? The overall air inside the lung is less when compared to obstructive lung disease. So, since the volume of air inside the lung is less, naturally, forced expiratory volume would be less because less air is going out. And forced vital capacity definitely drops because there is less air. So, FEV1 by FVC is more or less normal, or in some cases it may be increased. Clinically, patients with obstructive lung disease will have prolonged expiration along with wheeze and hyperinflated lung. So they breathe like this. While in restrictive lung disease, patients usually have rapid, shallow breathing. Like, now let's move on to the classical examples of each. Chronic obstructive pulmonary disease, bronchial asthma, and bronchiectasis are the examples of obstructive lung disease. COPD includes emphysema and chronic bronchitis. Examples of restrictive lung disease include pulmonary causes and extrapulmonary causes. Pulmonary causes include pulmonary fibrosis, pneumonia, ARDS, etc. Whereas extrapulmonary causes include obesity, where the expansion of lung is restricted, scoliosis, where the chest cavity itself is restricted, or neuromuscular diseases. So if you see wheeze plus prolonged expiration, think obstructive. And if you see shallow breathing with reduced lung volumes, think restrictive. In the next video, we'll start obstructive lung diseases. Think at the cell level.